Good morning, everyone. Thank you for joining the AAN's Resident Lecture Series. Today's topic is Clinical Approach to Peripheral Neuropathy. For questions, please use the Q&A feature and we will answer them throughout the webinar. Our presenters today are Dr. Erica Wong and Dr. Kyle Martin. Thank you both for presenting today, and Dr. Martin, I will turn it over to you.
Hi, everyone. Again, I'm Dr. Martin along with Dr. Wong today. We'll discuss the clinical approach to peripheral neuropathy. We have no disclosures to report. The objectives today, we'll review the approach to diagnosing major categories of polyneuropathy, and we'll review clinical cases for axonal neuropathy, acquired demyelinating neuropathy, and inherited demyelinating neuropathy. By the end, you should be able to classify common patterns, pick an efficient workup, recognize urgent red flags, and separate axonal from demyelinating processes. Now, peripheral neuropathy is a less precise term, often used synonymously with polyneuropathy and neuropathy. It can sometimes refer to other disorders of the peripheral nervous system, including radiculopathies and mononeuropathies. Neuropathy, those can also be classified as a mononeuropathy affecting one nerve, multiple mononeuropathies affecting multiple individual nerves, or polyneuropathy affecting peripheral nerves diffusely, but it's more nuanced than this simple classification. Peripheral nerves react to diseases in a limited number of ways, often present with a combination of sensory or motor symptoms in the feet and lower legs, which then spread proximately in the legs and then into the arms. So when you hear polyneuropathy, default to a length-dependent symmetric distal pattern, but again, as we will discuss, it's more nuanced than that. The clinical approach, with any patient, you'll start with a detailed history and exam. Then you'll determine the underlying pathophysiology, which may involve electrodiagnostic studies. Then you include some more laboratory studies. And then further, if needed, you can do genetic testing, a nerve biopsy, or even a CSF or more imaging. First, we'll discuss within the history the timing and distribution of the symptoms. So timing-wise, such as duration, you want to think of it as an acute process, such as days to weeks. Is it subacute, weeks to months, or chronic, months to years? And depending on that duration, may help you categorize what can be within your differential. Next would be progression. Is the progression of symptoms very progressive, so like a linear pattern? Is it more stepwise with clear time points of decline? Or is it relapse remitting, such that there's a decline and maybe a time point of improvement or slight improvement, and then maybe further decline after that? For distribution, you want to see how the symptoms are distributed throughout the body. Is it a length-dependent process? Is it focal, affecting one nerve, multifocal, affecting multiple nerves that are clear and delineated, or is it more diffuse processes affecting the whole body? For modality, you also want to think what fiber types are involved. So when I say modality, is it motor symptoms, which are more large fiber myelinated nerves? Is it sensory, which include both large and small fibers, or autonomic, which then includes small fibers as well? So for history, you think about which fibers are affected. So for sensory symptoms, large fibers will include the proprioception and vibration. Patients may say they have tingling, pins and needles, or balance complaints. For small fiber, which control the pain and temperature, patients may say burning, jabbing, shooting, or they may even have decreased pain or temperature sensation. But sensory symptoms are subjective, so there is some overlap between these two in the ways patients will describe them. Motor symptoms, because you'll search for lower motor neuron features such as weakness, fatigue, fasciculation, and cramps. And for autonomic symptoms, you're going to search for orthostatic hypotension, bowel and bladder dysfunction, impaired sweating, and or erectile dysfunction. Now for history, the next part was searching for potential etiologies. On this slide, I'm going to walk you through 4 buckets I screened every neuropathy patient for. The goal is to anchor the history so our testing is targeted for potential etiologies. So first, medical history. If diabetes or even impaired glucose tolerance is present, your base rate for a length-dependent axonal polyneuropathy just went up. A history of cancer raises 2 pathways: treatment-related neuropathy and paraneoplastic. Thyroid dysfunction, especially hyperthyroidism, can cause a large fiber pattern with areflexia. Second are medications and exposures in the med list. I usually think back to the last 6 to 12 months within their med list. Classic offenders are chemotherapy-induced neuropathy, vitamin B6 excess, and even zinc overuse, which then can lead to copper deficiency, are easy to miss. Someone on the question and answers asked about metformin in relation to B12. Well, metformin can reduce B12 absorption, compounding diabetic neuropathy risk. B12 deficiency causes a large fiber sensory loss and gait imbalance, while diabetes adds on that small fiber pain. This relates back to why which fibers are impacted can help rank your differential. Third is family history or inherited neuropathy risks. I literally asked the patient, anyone in the family with feet with high arches, pes cavus, hammer toes, maybe within their childhood were they clumsy or always tripping, bumping into walls, or even having them to have weak ankles. Lastly is occupational exposure risks, such as alcohol, recreational substance abuse, such as nitrous oxide, which then can inactivate B12, heavy metals, organic solvents, and even vibration tools. Now, for vibration, that can confound with entrapments. I remember having a construction worker who used a jackhammer on the job. That repeated vibration can make them at risk for carpal tunnel in the hands. Another short story is a truck driver driving throughout his career, all that vibration from the truck. He always leaned his arm on the window, and that vibration he felt in the whole truck gave him risk for cubital tunnel syndrome as well. Unprotected sex, risk for HIV, and also recent travel, such as infections. Examples here are leprosy and TB exposure. The point of this is when any of these are positive, it'll help with tailoring your labs and your differential. Physical exam will help our distribution, again, see what fibers types are involved. So vital signs, are there any orthostasis? Skin exam, looking for rashes, pigmentation, skin changes, or ulcers. A skeletal deformities, such as hammer toes or pes cavus, again, looking for those inherited neuropathy risks. For the motor exam, there's observation of muscle bulk, particularly intrinsic hand and foot muscle atrophy, as well as tone and strength. On a sensory exam, you're going to assess the large fibers, such as vibration and proprioception, and small fibers, such as pinprick and temperature. The tip here is vibration less than 10 seconds with 128 hertz tuning fork is a normal at any age. Reflexes, you're looking for any focal length dependent or diffuse effect on the reflexes. So now that you have the history and physical exam, let's discuss the phenotypes. Now, all of these in the red box are peripheral neuropathies, but these can further be classified into polyneuropathies. Remember when I said polyneuropathies are dominantly length-dependent processes? Well, it's because all these can present in a length-dependent pattern, but not always. The first one we'll discuss is isolated small fiber neuropathy, presents with a burning pain, paresthesias, and autonomic symptoms. Exam may be normal, and the EMG neuroconduction studies are usually normal, diagnosed by a skin biopsy or a quantitative pseudomotor axon reflex test. Now, the picture here shows all those distributions of how small fiber neuropathy can present, and I'll point out E. So you can see it starting in the feet, so it could present in a length-dependent pattern, or in D, it could present diffusely. So there's a lot of differences here in terms of how it can present. Next is the mononeuropathies, a single nerve distribution of weakness or sensory loss. A common example is carpal tunnel, often due to entrapment, trauma, or compression, with focal findings on nerve conduction study in EMG. Potential causes is a nerve compression against a hard surface, entrapment nerves and neuroanatomical space, transient mononeuropathy, such as repetitive actions that cause trauma to the neuron, like that jackhammer construction worker I mentioned, or non-compression related, such as infections, radiation, or cold. Next phenotype is multiple mononeuropathies, so the involvement of two or more non-contiguous motor sensory or sensory motor peripheral nerves, usually asymmetric, multifocal nerve involvement over time. So at first they'll just present with a unilateral ulnar nerve being affected, and then maybe a month later, the tibial nerve will start to be affected. It's very urgent when it's painful and progressive. Pain suggests ongoing ischemia, inflammation, or infiltration of nerve, such as vasculitis, lymphoma, or amyloidosis. These conditions actively damage nerves and can lead to permanent deficits if not treated quickly. Early treatment, especially in vasculitis or immune-mediated causes, can halt progression and preserve nerve function. In the Q&A, a resident asked about treatment options for vasculitis. Well, I recommend starting with high-dose corticosteroids, promptly when suspected or biopsy proven. And then you add a steroid-sparing agent based on etiology and severity, such as rituximab or cyclophosphamide in systemic vasculitis. But I will always involve rheumatology early, and depending on what health system you work in, they'll either drive the treatment strategy and monitoring, or they'll assist you with that as well. Next is a plexopathy. It involves a nerve plexus brachiolumbar sacral, causes patchy weakness and sensory loss across multiple nerve distributions. Usually a single limb, but could be bilateral. Common causes are trauma, neoplasm, or radiation. Next is a sensory neuronopathy. It involves the dorsal root ganglion, also known as ganglionopathy. It's usually non-length dependent sensory loss affecting face, trunk, limbs, and usually is asymmetric. Often autoimmune, such as Sjogren's or paraneoplastic cause. On exam, you're going to look for a severe ataxia with preserved strength, such as sensory ataxia and pseudoathetosis. Another board favorite for potential cause is vitamin B6 excess. Motor neuron neuropathy. The body of the motor neurons are affected, usually asymmetric and distal predominant. Pure motor involvement with wasting of the muscles, articulations, and weakness. Reflexes may be brisk or decreased. This includes ALS and spinal muscular atrophy. So I will note that depending on what source you're reading, ALS may be grouped differently based on which resource or book you're studying from. Well, let's go further into axonal versus demyelinating. Axonal neuropathies affect the longest nerves first, since these are the most sensitive to dysfunction. This usually causes the symptoms in a length-dependent pattern, starting at the feet. The progression leads to symptoms and signs that can ascend. Demyelinating neuropathies affect myelin throughout the peripheral nervous system, so short and long nerves can be affected simultaneously. So you'll both have both proximal and distal symptoms and signs that will constitute a non-length dependent pattern, and both the hands and feet can be affected at onset. But don't get fooled, because there are exceptions to these rules. Symptoms may still begin in the distal extremities, since the longest nerves have the most myelin. So it may start in a length-dependent pattern at first. However, the hands and feet may be affected simultaneously at presentation, and decreased tendon reflexes are usually more diffuse than just in the legs. So electrophysiology, we're talking mostly about nerve conduction. So in axonal neuropathies, the number of functioning axons is reduced. So fewer action potentials summate at the recording electrode. This leads to decreased or diminished compound muscle action potentials and sensory nerve action potential amplitudes, while conduction velocities are relatively spared. In demyelinating neuropathies, loss or disruption of myelin slows impulse transmission, producing prolonged distal latencies and reduced conduction velocities. Uneven demyelination among fibers can cause temporal dispersion, and if conduction fails in enough fibers, it results in conduction block with reduced amplitudes despite intact axons. EMG is healthy here as well, but I'll not elaborate on that in this lecture. Teaching Pearl is if velocities are normal, but amplitudes are slow, think axonal. If velocities tank and latency stretch with dispersion and block, think demyelination. So for axonal polyneuropathies, a vast majority are axonal, which mostly are acquired, such as diabetes, metabolic, causes nutritional. But there are some inherited ones. The most commonly is CMT2, or Charcot-Marie Tooth type 2. Axonal are usually slowly progressive, symmetric distal sensory loss, which progresses over many months to years. It can also cause distal weakness as the disease progresses, and you'll have diminished or absent distal reflexes. Numbness can extend proximally to the knees and then start to affect the hands, stocking glove. The teaching is that once the knees are involved, then you should start to see the hands become involved as well. Again, a lot of these are sensory symptoms, so there's a lot of subjectiveness, but you may hear patients say they feel rocks underneath their feet, or I think I have socks on at night, but I don't, or the sheets bother my feet at night. So you want to have the patients describe to you what they are feeling versus kind of ask them, does it feel like this? So for diagnosis, the generally accepted minimum standards of neuropathy, you need at least 2 or 3 of these, such as distal symmetric sensory symptoms as mentioned, distal symmetric sensory loss, and diminished absent ankle reflexes. You can see that there's a theme here. On electrophysiology, for nerve conduction, you'll see motor and sensory amplitudes are decreased, more marked in the lower extremities. And on EMG, you'll find axon loss, again, found more distally than proximally. Following the evaluation, though, a lot of these patients, even despite workups, 20 to 50% of patients are diagnosed with a chronic idiopathic axonal polyneuropathy or a chronic axonal polyneuropathy, such that there is no cause found on workup. So there was a 2016 study when these patients were evaluated, over half had a disease apparent on initial evaluation. So when they looked back, they found a lot of these patients had diabetes or CIDP or even neuropathy of a monoclonal gammopathy of unknown significance. Hereditary neuropathy is likely a large portion of these cases as well. So for your initial workup, tier 1, high yield, you'll do a CBC and a complete metabolic panel. You'll test serum glucose with hemoglobin A1C or fasting glucose, B12 with methylmalonic acid, and SPES with reflex immunofixation. Other tier one labs you can get are thyroid function tests, your inflammatory markers such as ESR and CRP, an ANA panel, and Foley. Tier 2 includes additional vitamin and mineral studies, such as with your history and physical exam, those are risk factors. HIV, HTDL1, Hep B, Hep C. These are more so after your history, you can include these into your lab panel. Tier 3, so if tier 1 you're not finding anything, tier 2 you're still not finding anything, you can move on to tier 3. You don't always have to do this, but you can do CMT2 genetic testing, biopsies through the salivary gland, for Sjogren's, abdominal fat PET biopsy, for searching for amyloid, a malignancy workup, paraneoplastic or autoimmune workup, and CSF studies. For familial amyloid polyneuropathy, you can do genetic testing for TTRs, known as transthread. Treatment-wise, for axonal polyneuropathies, patients should be informed that good treatment options do not necessarily follow from a diagnosis. Diagnosis provides the patient closure, education on the natural history of the disease, identification and treatment of risk factors, and counseling on prevention of potential future morbidity. Management of pain in axonal polyneuropathy is based on the treatment of painful diabetic polyneuropathy from the AAN guidelines, released in 2022. You can use gabapentinoids, SNRIs, tricyclic antidepressants, or sodium channel blockers. In my personal practice, I usually start with one of these and then up titrate until it's effective or if there are side effects that the patient cannot tolerate. If I max out the dose and there still is no improvement or slight improvement, then I may add on a second agent. Let's discuss demyelinating polyneuropathies. Myelin is directly injured, degraded, or abnormally formed, depending whether the cause is acquired or inherited. The axon underneath may remain relatively intact at first, although secondary axon loss can occur if the demyelination is severe or prolonged. The myelin breakdown leads to disrupted speed and efficiency of electrical signal conduction, leading to conduction that's slow or blocked. Some examples here are Guillain-Barré syndrome or AIDP, CIDP, MMN. These are more immune-mediated attack on myelin or Schwann cells. There's also metabolic, toxic, and systemic causes. And for inherited, the most common example is Charcot-Marie-Tooth type 1, which is genetic defects in myelin proteins cause an abnormal structure and function. There are electrodiagnostic demyelinating criteria for neuropathies. The European Academy of Neurology and the Peripheral Nerve Society produced 2021 guidelines. It's a long guideline that is very nuanced, so I recommend reading it after this lecture. Accurate diagnosis is crucial as some of these neuropathies, and particularly chronic inflammatory etiologies, do have treatment, such as IVIG, PLEX, and now also FcRn inhibitors, which are neonatal Fc receptors for IgG. Blocking the FcRn leads to increased degradation of IgG, reducing autoantibody burden without broadly suppressing immunity like steroids do. So, the core differences between acquired and inherited demyelinating neuropathies are in this table below. So the acquired demyelinating neuropathy is called a patchy or segmental demyelination, where damage occurs in discrete regions. This results in conduction block, temporal dispersion, and more variability between nerves or even between segments of the same nerve. And inherited demyelinating neuropathies, that they tend to show uniform diffuse demyelination, along the length of the nerve because the defect is built into the myelin formation or maintenance from the start. On nerve conduction studies, it produces a homogeneous slowed conduction velocities in all tested nerves without conduction block or temporal dispersion. The most hopeful contrast between the two are onset, distribution, and electrophysiology. Other clinical clues is global areflexia, hypertrophic nerves on exam, muscle weakness with relative preservation of muscle bulk, and motor symptom signs more severe than sensory ones. Here are just a few examples of inherited demyelinating polyneuropathies. Again, the most common is Charcot-Marie tooth. And for acquired, the ones you may commonly see in practice are AIDP and CIDP. So for immune-mediated, here are some examples. So AIDP is an acute ascending paralysis, areflexia. You'll see CSF immunocytologic association. It's often present, but not always. For CIDP, the patient will have symptoms of for more than 8 weeks. They'll have symmetric weakness or sensory loss, and they usually have good steroid and IVIG response. For MMN, or multifocal motor neuropathy, it's asymmetric, motor only. They'll have conduction block. Anti-GM1 antibodies are possible on your lab tests, and they usually have a poor steroid response. For paraneoplastic infectious toxic causes, you can see those below. Neuronal and TNF alpha inhibitors are common ones. Key workup will be the CSF studies, nerve conductions, EMG, autoimmune panels, imaging, and serologies. For inherited demyelinating neuropathies, again, the most common is Charcot-Marie tooth type 1A due to a PM22 duplication. Onset usually in childhood or adolescence, and features are foot drop, pes cavus, and distal muscle atrophy, as well as steppage gait. There are other types as well, and I'll list them below for you here, and you can see the different genes that are affected. Clues to suspect an inherited etiology is the early onset and slow progression, the foot deformity that I mentioned multiple times in this lecture, the lack of inflammatory markers or conduction block, and a positive family history. Again, here I've mentioned the nerve conduction studies, what you'll see for inherited demyelinating neuropathies, what you will see, such as a uniform slowing, conduction block is usually absent, and temporal dispersion is rare. So again, a key distinction, this will help you on your board exams, is inherited is uniform demyelination, and for acquired is patchy with conduction block. Diagnostic tools, you'll use genetic testing, and rarely needed, you can sometimes use nerve biopsy, which may show onion bulbs from chronic demyelination and remyelination. So when to refer genetic testing? So when you have a patient that has a young onset of symptoms, a suggested family history, and that typical phenotype, and when you get your electrodiagnostic study, you see those features as mentioned above. Or tip, uniform, slow nerve conduction velocities in the legs and arms, think inherited, patchy, slow with conduction block, think acquired. So I mentioned this multiple times, it's probably important to remember. So let's think about urgent red flags you need to know and you can't miss for neuropathies. So painful, progressive, asymmetric mononeuropathies, think vasculitic mononeuritis multiplex. For rapidly progressive weakness with areflexia, think GBS plus its variants. For severe neuropathic pain with weight loss and systemic features, think amyloid vasculitis or paraneoplastic. For severe autonomic failure, think such as orthostasis, gastrointestinal dysmotility, impaired sweating, think autonomic neuropathy or amyloid. So pain plus asymmetry plus aggression equals urgent workup. Why? Because treatment can stop progression and save the nerve. Now, I will also mention here that most axonal neuropathies are slow. So the key points here are the painful, progressive, neuropathic symptoms that are usually pretty quick. So clinical approach summary. Get the history and perform the physical exam, as you do on every patient, such as you get the timing, distribution, and find out which fibers are affected. Define a neuropathy clinical phenotype. It helps you narrow differential. These three things, such as the history, the exam, and phenotype together, leads towards that high-yield workup. Nerve conductions and EMGs are valuable, but the neurological exam is the most important because it's going to tell you, again, all the things to distribution and which fibers are affected. If you know the clinical phenotype, along with the timing, distribution, and fibers affected, then you can easily help yourself by looking up what the potential differential is. So Workup, based on that phenotype, you're going to test for metabolic, infectious, genetic, inflammatory, autoimmune causes, and eventually you'll get to your diagnosis. So this was another question: why order a nerve conduction or EMG for polyneuropathy? And the reasons why is it helps you classify axonal versus demyelinating. It can help you localize to search which nerve is involved, or is it the root or plexus. It can help you establish baseline severity, such as in AIDP or CIDP, and it can guide therapy, such as justifying IVIG for CIDP. It also rules out mimics, so such as plexopathy, motor neuron disease, and entrapments. You can usually defer in classic mild length-dependent diabetic polyneuropathy when results won't change management or when you're pursuing a small fiber disease process. The way I think about it is, if I get this nerve conduction study or EMG, will it change my diagnosis or will it change my management? And that's how I really decide which patients I will get it on. So in brief, a practical treatment ladder. For disease, think more disease modifying where appropriate, so such as glycemic control for diabetes, immunotherapy in cancer or in autoimmune processes, alcohol cessation if they are alcoholics, and chemo dose adjustments. Symptom control, so for pain control, start with one pain agent, titrate, and then combine as discussed. For autonomic, if that's involved, think fluids, compression, or if they need medications such as Mediterranean fluorocortisone as indicated. And lastly, everyone, general care. They should get physical therapy, occupational therapy, discuss foot care, and especially an important one, fall prevention. So now I'll turn over to Dr. Wong, who will discuss representative cases.
Thank you, Dr. Martin. So now I'm going to talk about, I'm going to go through 3 representative cases and kind of illustrate what Dr. Martin's taught you so far. So our first case is a 66-year-old man, has a history of diabetes, and he says that he's had 2 to 3 years of numbness and tingling in his feet. He's maybe noticed a little bit of worsening since symptoms started. He doesn't think he has any weakness, but he describes the sensation of his feet as always walking on rocks. On his physical exam, his mental status and cranial nerves are normal. His strength is also pretty good, except that he does have a little bit of weakness, 4+ out of 5, in his distal feet with toe extension and flexion. On his sensory exam, he has diminished touch and temperature up to the ankles and decreased vibration and proprioception at the toes. His reflexes are normal, except that his ankles are hyporeflexic bilaterally. His gait is normal. He does have a little bit of difficulty with tandem, as well as difficulty with walking on his toes and heels. So far from your history and physical, you've kind of gathered that he has predominant sensory features, although he does seem to have some very mild weakness as well. So we kind of go to his nerve conduction study. So there's a lot of numbers on this screen, but I'm just going to point you to a few important features. So you can see up here, I'm going to orient you. This is the motor nerve conduction study. And on the left-hand side, you'll see that their nerves are labeled, left perineal, right perineal, and then as well as the muscle that we're recording from. And then you'll see in red, the latency, amplitude, and conduction velocity are kind of the 3 major numbers that I think are important and look at. And I'll tell you that on this slide, all of his numbers are normal. So his motor nerve conduction studies were normal. And then we're going to go to the sensory nerve conduction studies. Similarly, just to orient you, this is the list of the nerves tested and where we're recording from. And then you can see that I've highlighted in red the abnormal values. So his left superficial perineal snap was absent. And then bilaterally, the amplitudes were a little bit diminished. So normal is 6. And his conduction velocities were essentially normal. On his EMG, he only had a few distal muscles tested, which showed just very mild polyphasic units in the left TA, which represents a chronic neuropathic process. So thus far, we see that on nerve conduction studies, he had a normal motor nerve conduction study. He had mildly reduced amplitudes on the sensory nerve conduction studies and some kind of chronic reinnervation, but very mild on his EMG. So what type of neuropathy is that? So based on his presentation and his EMG, this is a mild sensory motor polyneuropathy. There are no demyelinating features. It's predominantly axonal. And his risk factors are definitely his diabetes. We did send off kind of our other tier 1 labs, SPEP and B12. And we didn't really feel the need to send other labs because it doesn't have any red flags, slowly progressive, pretty mild exam. But because the symptoms were bothering him, we did start him on gabapentin, and then we instructed him to increase this as tolerated. So that's our first case of a kind of milder axonal polyneuropathy, very commonly seen in clinic. Our second case, this was actually one of my first cases when I was a neuromuscular fellow, a 14-year-old girl who presented with weakness and difficulty walking for 2 months. She complained also of numbness of her feet and frequent falls. And this was kind of progressive over the last 2.5 months or so. She said that for the first month, she only had numbness in her feet. And then in the second month, she actually developed difficulty walking. But by the time that she got to us in the EMG lab, which was, I believe, between her second and third month, she had felt like she was slowly improving. She also did have some numbness in her hands bilaterally, and she didn't remember having any illness prior to her presentation. Interestingly, she actually had a similar presentation 4 years prior. At that time, she said she had difficulty running with her numbness in her feet. Difficulty with running and numbness in her feet. It took about 4 months to recover from that episode, but the apex of her symptoms occurred within the first month, unlike this time, which it seemed to be more prolonged. She didn't have any other medical or family history. So on her exam, her mental status and cranial nerves were intact. She did have some mild weakness distally of her hands and her feet. And sensation was also affected in her hands or feet. She had decreased large fiber function below the ankles. Small fiber function below the ankles and in the hands up to the wrists, and then decreased proprioception or big toes and vibration up to her ankles. She had no reflexes. And then she was noted to have this mild tremor in her upper extremities. She had this wide-based ataxic gait, and she had a really hard time with tandem. So in the EMG lab, we saw that on her sensory nerve conduction studies, you can see they're all NR, which is no response. So we checked nerves in the upper and lower extremities. So you can see left, ulnar, median, and radial in the upper, and then bilateral sorals, and all of them are absent. And on her motor nerve conduction studies, I'll also just highlight a few abnormalities. There's many, but you can see the arrow to the left. The distal latency of her left median motor nerve is extremely prolonged. It's 17, plus milliseconds, and in normal individuals, it's less than 4.5 milliseconds. So again, very prolonged. And then she also had this incredibly slow conduction velocity, only 9 meters per second. And you can see this was also seen in another nerve, the left ulnar nerve. Her amplitudes were pretty diminished. Left median was only 0.4. And then the left ulnar, it was a little bit better, but still pretty low. But importantly, in the left ulnar, what we see is that there is this drop in the amplitude as we stimulate proximally. So in the wrist, we stimulated, it was 2.3. But then when we go up to the elbow, it drops to 0.4. And so this signifies conduction block. And then same thing in the fibular nerve, we see that, again, her amplitudes are on the low side, but she has an amplitude of 1.5 at the ankle, and then it was unobtainable at the fibular head. So this was complete conduction block. And these are the actual waveforms from her study. So you can see on the left-hand side, this is actually representing temporal dispersion. So you can see that when you stimulate proximally at the wrist and then move up to the elbow, that this waveform becomes like more multiphasic. It's kind of serrated. It has a longer duration, and that is what you would see when the temporal dispersion is more pronounced in a demyelinating disease. And on the right-hand side, you see that, and just to let you know, this the proximal stimulation at the elbow, it is magnified just to see the waveform better. So it is actually probably half the size of this. But you can see that there is actually conduction block, so the amplitude does drop, and it also again becomes more multiphasic and serrated, and so representing both conduction block and increased temporal dispersion. And then in the fibular head, you see kind of complete conduction block as we moved proximally in the nerve. Not surprisingly, her F waves and H reflexes were all absent. And she also had kind of a limited needle exam, but it showed a chronic neuropathic pattern. And so in this case, we see that there are multiple things that point to a acquired demyelinating polyneuropathy. She has really marked slowing of her conduction velocities, temporal dispersion, and conduction block. But again, as Dr. Martin mentioned, the history and physical are really important in determining the diagnosis as well. And because this was the second time this had happened, and the course was longer than 8 weeks, we thought that this was most suggestive of CIDP, or chronic inflammatory demyelinating polyneuropathy. She was actually an inpatient at the time, so she got more workup actually. And we found they actually did a lumbar puncture on her, and her protein was elevated with normal cells. I will say that some of this workup was actually done before we got the EMG. So if we had the EMG, not everybody would have gotten the remainder of this workup, but it's still interesting to see. And then she actually had got an MRI of her total spine with and without contrast. And this is just a representative slide, but she actually had enhancement of her C4 nerve roots all the way down to her sacral nerve roots. So you can see on the right side, you can see the kidneys lighting up. So there's contrast there. But you see these, it's a little hard to see, but these little things right here, those are her nerve roots enhancing. And it was all the way up and down her spine. And the radiologist actually put, consistent with CIDP. So she was given IVIG in the hospital, and then when she went home, she was continued on monthly IVIG infusions at home, and she had marked improvement of her symptoms. And by her 6-month appointment, she had already her symptoms. She still had some symptoms, but they had gotten a lot better already. Okay, and then our last case here, we have a 30-year-old man presenting for evaluation of peripheral neuropathy. He has no significant history. But he says he's actually had a foot drop for years. He initially noted that he was clumsy and tripping over his feet as early as his teenage years. And then this slowly got worse over time. When you ask him, he says, yeah, I have a little bit of tingling and numbness in my hands and feet, although they don't seem to bother him that much. And notably, he has multiple family members with similar symptoms as him. On his exam, his mental status and cranial nerves are normal. He does have this atrophy, this distal tapering of bilateral legs that you notice. His strength exam shows that he has weakness of his intrinsic hand muscle, so 3 out of 5, and FDI, ADM, and his APB. And then lower extremities, he also has good strength proximally, but almost no movement of his feet. Coordination, he had mild dysmetria with both finger to nose, finger, and heel to shin. And his reflexes are down everywhere and absent in his lower extremities. And he has a negative Babinski. For a sensory exam, his pinprick exam, he had was diminished distal to his ankles and below his elbows and the upper extremities. Temperature was diminished distal to his calves and as well as his elbows. His proprioception was impaired at the toes, and then his vibration was absent at the toes and ankles, or in his lower extremities, but were also a little bit reduced in his fingers as well. And he had this staffage gait. He did have some additional lab testing which showed a borderline B12. He did have an elevated A1C, thyroid and SPEP were fine. And then he had some additional MRI L-spine imaging, which showed some mild arthritic changes, but nothing that really explained his symptoms. So then he got an EMG. So this is his motor nerve conduction study. And I'll point out some similarities to our last case. So he also had, well, this patient had no responses in the lower extremities. And then in the right median nerve, you see this is a prolonged distal latency, also prolonged in the right ulnar nerve. And again, very slow conduction velocities. In the upper extremities, normal is around 50 meters per second. So this is incredibly slow. And then he had really reduced amplitude. So it's a little bit, sometimes it can be hard to judge conduction block in patients with really reduced amplitude, but there's no clear conduction block. Although again, this is a real life patient. So sometimes the lines are a little bit blurred, but really prolonged distal latencies, incredibly slow conduction velocities without clear conduction block. And then he had absent sensory potentials as well. And in this case, the needle exam was deferred. So he also had a severe demyelinating sensory motor polyneuropathy. In his case, he had those prolonged distal latencies, really slow conduction velocities, and could, be an example of what you might call uniform slowing, as Dr. Martin mentioned before, without obvious conduction block on his study. But also, what was important to note is kind of his history, right? So he's had symptoms for decades and also has multiple family members that are involved. And so that should really make you think that this could possibly be an inherited polyneuropathy. So based on that and the study, CMT1 type 1A was suspected, and he did actually have genetic testing for that, which came back positive. So when you have an inherited neuropathy, treatment is symptomatic at this point. We often will include our rehab colleagues to help us with bracing. We can give them neuropathic pain medications if they need it, although in many patients with inherited neuropathies, they tend to have less pain than our acquired neuropathies. PT and OT can also be really helpful. And then, of course, genetic counseling is really important for all these patients to have. So some take-home points, your history and physical exam are still what is most important. The EMG will help guide you, but, we've all had those circumstances where sometimes the EMG doesn't seem to quite fit what we think is going on. And in those cases, you should go back to the history and physical exam and really hone in on details and see if maybe that nerve conduction study needs to be repeated, or, if there is something else that's missing. And then today we included some of kind of all types of peripheral neuropathies, although we wanted to focus predominantly on the polyneuropathies. And in those cases, I want you to think about two major buckets: if it's axonal versus demyelinating, or if it's acquired versus inherited. And if you can figure those two things out, you've really narrowed down your differential quite a bit. And that is it. I think my next slide is just references. So thank you all for your attention. I think I'll stop sharing and then we can start answering some questions. I think that Dr. Martin already answered this one, but I'll just mention it briefly because I do think it's an important one. And that's like, when should you get an EMG or nerve conduction study? And basically his point, I think, is if you have a classic neuropathy patient, an older patient who has had symptoms for years, so a chronic presentation with an exam that fits, right? So distal sensory loss, maybe mild motor involvement in the feet, and decreased reflexes as well. If that patient is a classic neuropathy patient, we don't always have to get a nerve conduction study EMG. But if there are kind of red flags, right? So the patient's younger or the symptoms are progressing quickly, which for neuropathy, that's months. So if something, in our axonal neuropathy patients, if you examine them in 6 months, they shouldn't look different to you. Right. So if the patient has progressive symptoms, then that should be an indicator to look further, to do an EMG, to do more labs. So it's really just looking for those more atypical circumstances. And I will also say, in patients who have more than a mild neuropathy, so moderate to severe, especially if that's the first time they're presenting to us, we will often still get the nerve conduction study EMG as well, just to characterize them better and also look at the severity, as Dr. Martin mentioned as well. Another question that I saw that we didn't answer in our talk was, what is my personal experience in treating CIDP with steroids versus plasma exchange? And I will say we didn't go into this. There's a lot of types of CIDP. So you have your classic CIDP, but there's a lot of atypical. There's typical and atypical CIDPs, which we didn't go too much into because that could be its own topic. But there are two kind of major phenotypes of CIDP. One is kind of like MS. There's like a primary progressive type where they're usually older patients who kind of just, they get a little worse over time, and the IVIG maintains them, but they don't really get back to their baseline. And you have this other phenotype that almost looks like relapsing remitting, where there's, they may have an exacerbation and then they kind of get pretty close to their baseline, and then months to years could pass before they have another exacerbation, and then they get back to normal again, or close to their baseline. So your choice of medication will vary because, for example, I generally don't like to choose steroids in a patient who I think is going to be just progressively worse, because then there isn't really an endpoint to giving them the steroids. Whereas if their phenotype is that they get an exacerbation and then tend to get better, I would consider steroids in that patient. Usually it's like prednisone, 60 milligrams, and then they taper very slowly over the course of over a year, like many months. But I would say our first choice for most patients with CIDP is IVIG. So typically we do IVIG, and they get an infusion. Usually the maintenance is 1 gram per kilogram every 3 weeks or so. Sometimes we extend it to 4 weeks just for convenience, but it's like every 3 to 4 weeks. And if that doesn't work, you might try plasma exchange or rituximab. So we might, again, think about steroids if they're not tolerating or not responding to one of those therapies. Going back down, let's see. And I think we answered this as well, but in terms of for suspected peripheral neuropathy, the first 3 clinical signs you look for, again, sensory findings in the feet, and diminished reflexes with history complaints suggestive of neuropathy. I think the reflexes are actually really important because I've actually caught a few cervical myelopathies when the ankle jerks were actually brisk and not down. So you do want to make sure you're checking those ankle jerks in these patients and making sure that it is consistent with a peripheral nerve process. Because there are some cervical myelopathies, especially when they're milder, they can kind of mimic peripheral neuropathies, having bilateral sensory. Their legs feel odd to them, but they instead have a brisk ankle jerk. So make sure that their ankles are down if you're thinking it's a peripheral neuropathy.
So there are a couple of questions in the chat.
Mm.
One of the question is, can you please talk a little bit about B6 toxicity? Is there a serum cutoff beyond which B6 is concerning? So I would say, it depends on which lab you're using, but even modest levels in B6 can cause symptoms. And if you have a patient with an elevated B6, but they're not showing you a ataxia or dysesthesias, and it's going to be hard to correlate that level to their symptoms. But even if a patient has symptoms, and even if the level is above that cutoff based on what lab you're using, then it's warranted to search their medications or minerals or vitamins to see if they have an exposure, and then remove that exposure if there is. If the symptoms go away, great. And maybe it was from that modest or even very little B6 toxicity. If it doesn't, I would still search for other potential causes.
I think it's people take a lot of vitamins these days, and a lot of times they don't need to. So I definitely would ask about their vitamin B complex or vitamin B consumption. I see another question. I think, what is the nerve conduction study pattern in nodopathies? So especially, I think when we think of nodopathies is a. Go ahead, Doctor. Go ahead, Dr. Martin.
I was just marking before. You can continue.
Oh, okay. Well, I think that it depends. Nodopathies is kind of a category that is becoming its own category. I would say it's for example, there are patients with CIDP that are considered that they might actually have nodopathies instead, so for example, there's like anti-neurofacin 155 antibody. There's a couple antibodies that have been associated with them maybe being more like a nodopathy, but they're currently classified as like CIDP right now. So I think for those nodopathies, they would look demyelinating. I don't know if you had a more specific question than that, or if Dr. Martin, if you had any other thoughts about that specific. I don't know if you had anything else that you wanted to say about the question.
I think you covered.
Yeah. So, right now there's like within specific types, we see nodopathies, and most of the time that's in our demyelinating polyneuropathies, where we think that they're the pathophysiology is more that they're nodopathies, but they still look demyelinating on nerve conduction study. And then another question is FcRn inhibitors and CIDP. So this is very new, and I think we're still figuring that out. I think I think it's a little too early to say. I think there are still studies coming out about using it in CIDP. I would say that right now I still use kind of our traditional medication. So I still use IVIG, and then if that doesn't work, then I might think about using steroids or rituximab. And then if that doesn't work, then I try plasma exchange, although plasma exchange is usually my last resort. So I think instead of plasma exchange, I might consider FcRn inhibitors at this point. But it's still, again, really, I think early, and we'll see, in the next few years, how we use kind of just like, initially when FcRn inhibitors were introduced for myasthenia patients. I think it just takes a little time to figure out these new medications, like where they fit, the landscape. But I tend to use it in patients after they've failed other kind of my typical regimen. This is a good question. So the question is, how long in your practice do you give IVIG and CIDP? And when do you decide to prolong administration duration? So like, how do you decide, like in terms of when you give IVIG to CIDP patients, when do you stop, right? Or do you continue, or what happens? I think that essentially I'm trying to remember what year. There was a paper that came out, I think in 2021. I'm trying to remember the year, but essentially it has been shown that about half the patients that you stop IVIG in with patients with CIDP do okay. So about 50%. And so I tell most of my patients that if they have been stable, and this is kind of arbitrary, but I think me and many of my colleagues would say, if they're stable for about a year on their symptoms, then you can think about either tapering or stopping their IVIG and kind of giving them an IVIG holiday, as we call it, and just see how they do. And if some patients do fine and they don't need the IVIG anymore, and other patients will decline and you'll have to put them back on it. So, but I do try to do that with all of my patients, is if they're stable, to talk about, okay, now that you're stable, there is a good chunk of patients who do fine without IVIG. We should give you a break and see how you do. And that's kind of how I approach it. In patients who, you feel like a little bit more hesitant to stop the IVIG, you can also decrease it a little bit slowly over time. So for example, instead of giving them every 3 weeks, you can get every 4 weeks. And then every 4 weeks, you can give it every 6 weeks. You can kind of, increase the frequency between infusions, or just decrease the actual grams that you're giving them for each infusion. So you can decrease it slowly either way, also just to kind of see how they do as you decrease it, if they're stable. But usually I try to just stop it, or slowly decrease it, depending on how kind of fragile I think the patient is. I don't know if there's anything else. I think we answered.
Any other questions we answered during the talk, or you mentioned it already?
Okay.
Trying to see if there's any more that we missed or did not talk about. I think someone mentioned TENS units for neuropathy meds aren't affected. Uh, TENS can be effective, such as reducing pain, but usually in the acute term. I would be careful with patients with defibrillators or cardiac implants, as that could be a contraindication for the TENS unit. So I would say the TENS unit really what it's doing is giving you that acute pain relief, so that way you can participate in therapy and do exercise and help kind of way retrain your nerves to tolerate the pain and improve your quality of life. That's what I would say. I would use a TENS unit for. For certain patients, it takes all their pain away, but it's really only for the acute period.
Thank you for joining today's AAN Resident Lecture Series subspecialty webinar. A recording of today's webinar will be available on the AAN's YouTube channel.